Koso is a Professor of Public Health and Epidemiology and a Fellow of the Royal College of Physicians and Faculty of Public Health. And she really focuses a lot on lifestyle risks, risk factors and prevention of chronic diseases. So, and I didn't even know this, that you've been the World Health Assembly, United Nations General Assembly meetings and TEDx talks. So, I mean, wow, amazing. So we've got a little bit of an outline that what we're going to talk about today. But I wondered if you wanted to just give us a quick overview on COVID-19, because I think, you know, obviously we hear a lot about it in the media and things, and we know a lot about it. But, you know, just in a nutshell, just to give us a quick summary.
Yeah, it's great to be here, and I much prefer this type of informal audience, and especially as there's some names that I can recognize. Hi, Kat. Most of my work, so I'm a professor of public health and epidemiology, most of my work is on how we put in lifestyle changes for chronic disease, so diabetes, heart disease, etc. What we're seeing now is that what we eat, how much we exercise, whether we smoke is actually impacting infectious diseases like COVID.
Yeah.
And so I'm doing quite a bit of research now also on COVID and who's at risk. So I thought today we could talk a little bit about what COVID is, who's at risk, and now as we're coming out of lockdown, how we can stay safe and be sensible.
Yeah.
So I think, I mean, I'll give a very brief overview because I think most of the audience would already know quite a bit about it. So COVID, you've probably heard of the term coronavirus, which is the type of virus named after the shape. And there are several others that are less kind of harmful, such as even the common cold. But this one is a zoonosis, which means it's been transmitted from an animal, in this case a bat, to a pangolin and then to humans. And you've probably seen this lovely picture of the spherical virus with these little spikes, and that's what we refer to as a spike protein, and that's the bit that latches on to the cells. And there's something called the ACE2 receptor on the cell, and the reason I mention that is because that's the reason why some people get this more severely than others.
And that's
it depends on how much
to kind of ask, because, you know, obviously we've had viruses, we have flu virus, you know, annually changes, colds, coughs, all of those things, but this one's really had, you know, sort of a devastating effect, and, you know, sometimes more so in, you know, some certain areas and populations than others. So so that's why it's important. You know, do go on about the ACE2, because, you know, that's really interesting.
Yeah. So look, most people when they get coronavirus, we think maybe between 5 to 20% of people in the UK have probably had this. Most people will get a very mild illness, and some people won't even know that they have had it. Symptoms that we typically see are fever, shortness of breath, myalgia, cough. Some people would also get headaches, dizziness, loss of sense and smell, taste and smell, and also some gastric upsets as well. We are seeing some kind of rare reports of skin lesions. You may have seen some images of people with lesions on their hands, their feet, extremities. And also some neurological problems as well. When coronavirus first came about, we didn't really link the two together, but now we're seeing that all of these are part of the spectrum.
I know. Oh, sorry, I was just going to say, on the NHS website, when I was looking into it today, they were talking about sort of the 3 most common or symptoms, you know, being the persistent dry cough, the temperature above 37.8, and now, you know, loss of sense of smell and taste, which maybe didn't come through right at the beginning, but now, you know, we know more that is a feature of it.
Yeah, I guess the reason is most people wouldn't actually, when they go to hospital, they probably wouldn't even report that. But now with these apps at King's College and elsewhere that are the Zoe app, etc., they're collecting more data. And I guess when you're typing the data in yourself at home, you're more likely to put in these milder symptoms as well. You're less likely to tell the doctor.
Yeah.
So most people would have these be fine at home, and it can take a few weeks to get better. In around 5% of people around day 7 or 8, their bodies go into a hyper inflammatory state. And these are the people who end up having to go to hospital and have more severe disease.
Because it has been quite frightening, hasn't it? Sort of what we've been hearing in the media. And you and I were talking about this earlier, and I was saying, you know, to hear every day how many people have died, and you know, the R numbers. And one of the things is, you know, we know that there are excess deaths, but you know, one of the things I would have quite liked to have known was also the comparators. You know, this time last year, how many people would be dying compared to this time this year. And something interesting that you said to me was about that 5%, or the people that tend to get it who are sort of compromised or with lots of or comorbidities, that it shortens their lifespan by about a year. Is that what you said?
Yes, so there are many different ways to look at it. We've really been, well, I think the reporting has been quite emotive, and obviously for a lot of people it has had very severe outcomes. But I think the reporting of the different risks for different people could have been better. You know, we can still explain that in a clearer way. For most people, around 95% of people, they wouldn't need to go into hospital. People over 70, or people who are younger but have quite severe diseases to begin with. So they may have heart disease, cancer, hypertension, severe lung disease,
so
diabetes.
The higher risk people that we're talking about, the higher risk ones with more than one, you know, sort of illness or more than one other factor.
Yeah, and for younger people, obesity is a big one. So people under 50 in particular, we're seeing very high rates of obesity for those people who are being admitted to hospital. So I think it's important to put it into context. So there have been a lot of deaths. When we look at these deaths, these do tend to be people who have chronic disease or life-limiting disease in some cases, unfortunately. So it has accelerated the death of many people. Around 10% of the deaths have been in frontline workers, such as healthcare workers, because they have a much higher viral load. They have much higher exposure to the disease. Around 1 in 5 of the deaths reported are in elderly and people in care homes. And so, again, another way to put it into context is that there have been more people over the age of 100 who have died with this than under the age of 30.
Okay.
So it really, and we don't tend to think of many people being centenarians or being over 100.
Yeah,
so
I know. I was just trying to sort of figure that out in my head for a moment, because I thought that's not. I mean, I don't know exactly how many people over the age of 100 there are in United Kingdom, but we don't really tend to think about there being a large number, do we? And I mean, and I'm thinking, about, you know, as a GP in my practice, I never really saw many or went on home visits and saw many. I have seen a few though, actually, but you know, not as many as not that many at all.
They're probably avoiding you, Shahzadi.
Could be, you know, like I said, you know, maybe a high viral load and exposure, I don't know. But so, you know, I think...
So there's a professor called David Spiegelhalter who's on BBC Radio 4 quite often. I like the way that he describes the risk. So he says if you're aged under 40 and you don't have any other diseases, then your risk of dying from a car accident over that period was higher than dying from coronavirus. If you're under 25, then your risk of dying from flu or pneumonia is higher than dying from coronavirus. Just again, to put this into context. So this really is a very severe and dire disease for those who are older or have chronic conditions, but for those who are younger and fit and healthy, then for most people, it's a mild self-limiting disease.
So I'm going to play a bit of devil's advocate here in a way. I sort of jumped the gun and sort of, you know, if you know, we're saying that in the younger population, you know, the under 20s, you know, sort of that, you know, the risks from them dying from cold and flus or cross, you know, sort of road traffic accidents tend to be higher. What about getting them all back to school then?
Yes, so Good question. And the government are trying to get everybody back to school in September.
Yeah.
Some countries, such as Ireland, they did reopen the schools for several weeks before the summer holidays. And so we have data from there. And so there's one very nice study in Ireland that had around 1,000 students and teachers in the school. So everybody, when they went back to school, were tested for COVID. There were 3 cases of COVID.
Okay.
But out of those 1,000, there wasn't even one case transmitted to the child, to any child in the school.
Okay.
There were 3 cases from adult to adult transmission. So we really are talking about almost 0 risk to children. Obviously, if a child has a chronic disease or a severe disease, then that's a different matter.
Or
and they should
compromise, I suppose, you know, then obviously those kind of things do increase risks, you know, and I suppose maybe, you know, there are those factors, and also there's, I suppose, concerns that even if they're low risk, if their parents, you know, have got other risk factors, or grandparents, or their mother is pregnant, then I suppose it's a domino effect from there. So I mean, I can understand that, but you know, one of the things is particularly, I think, which was highlighted when you said about the frontline workers when the deaths were happening, or when they were being reported sort of continuously. Well, a lot of them tended to be people of colour. You know, when the initial photos came up, and there's been a lot talked about what are the risk factors. You know, is it being a person of colour? Is it lifestyle? Is it living in bigger families, extended families, multi-generational? Or is there an inherent, you know, you mentioned ACE2 earlier on, is there an inherent sort of genetic aspect that, you know, people of colour tend to be at higher risk?
So it's all of the above. So you're right, both in the UK and the US and elsewhere, we're seeing consistently that people who from Black ethnic groups, Latinos, people from the Indian subcontinent, they're all at higher risk. People from Southeast Asia tend to be at lower risk.
Okay.
And so in the UK, for the Black population, the risk is 4 times higher. So it's very significantly higher. Now, some of the factors are socioeconomic. For example, living in houses with more, or areas with more crowding, which is a risk factor. Occupational, people of Black and ethnic minorities tend to more likely be frontline workers, including healthcare workers.
Yeah.
Higher risk factors, so diabetes, hypertension are higher. So if we account for all of those, for those 3, then the risk goes down, but it's still double. So the risk of dying is still double if you are from a Black and ethnic minority, and that element is thought to be genetic, probably genetic. And some communities, for example, Black African and Afro-Caribbean communities in the UK, they do have very different levels of ACE2, and that's why some antihypertensive medications, for example, you wouldn't use in those patients for the same reason. So we don't have the full answer yet, but we do think some of that is genetic.
And leading on from that, you know, one of the things is that obviously I look after a lot of women, midlife women. We talk about, you know, sort of menopause, estrogen, and there's been a lot about the estrogen effect and whether or not that is a protective effect. And that's why men have been, you know, I think it's almost like a 2-to-1 ratio. You know, more men have been dying from this than women have. And also, you know, there was in the papers, I did read that in New York and in LA, the groups of men were going to be given estrogen to see if that helped with their immunity. Which, I mean, I don't know, you know, but obviously, but you know, I was a bit confused with that, because I thought, well, you know, if obesity is a risk factor, and we know that fat cells produce estrogen, then, you know, sort of obese, why are we saying then obesity is a risk and yet estrogen is protector? To me, it seemed a bit contradictory. But I mean, you mentioned ACE2, that might be more of a factor rather than estrogen itself. Yeah,
so when we look at all of the deaths, unfortunately, around 3/4 of them are in men and 1/4 in women. The risk factors do account for some of that difference. So the higher rates of hypertension and heart disease, particularly in men, do account for some of that. The ACE2 levels also differ between men and women and between adults and children. And so that's thought to be protective, slightly protective in women and children. I have personally not, I did see the proposal to give estrogen to men, but I haven't seen enough data that shows that estrogen is the actual cause, and therefore would be able to use that as a treatment. I mean, it's something that it needs looking into. But fat cells, for sure, for other viruses as well, for the flu, for other bacteria like TB, can act as a reservoir for transmission. And so similarly with coronavirus, we think that the fat cells may act as a reservoir for the virus.
I mean, that's really interesting. I mean, I think that's been helpful to try and sort of allay some of the myths. And, you know, it really does come back to lifestyle. You know, there's a lot of factors that we can try and make differences, you know, in our own lives to improve our health. And it's not just from the point of view of coronavirus, you know, it's from so many factors. I mean, last week I was reading about, you know, 23% of breast cancers could be avoided because, you know, adjusting modifiable lifestyle factors, you know, diet, exercise, you know, healthy fats, all of that aspect, reducing alcohol, stopping smoking. You know, there are a number of things that we can do together, and sometimes it is harder in different population groups. And, you know, socioeconomic factors have a huge part to play. But sort of moving forward, coming out of this, trying to get back into some semblance of normality, traveling into work. You know, one of the things is that I'm traveling on the tube, everybody's wearing a mask. There's a part of me that thinks, well, how much is that actually doing, that mask? I mean, the particle's so tiny that sometimes some of the masks are, I mean, I think I really don't know how much it's doing, and there's that whole debate of whether or not the government should make it mandatory or not. You know, tell me a little bit more about your thoughts on that. And
so as you say, the virus is minuscule. It's 0.12 micrometers, so that would go through almost all materials that masks are made from. So I think if we take a step back and look at how the virus is transmitted, so you have the droplet transmission, which is usually when somebody is symptomatic. For example, they're coughing and larger droplets are being spread. And that's where the social distancing comes into play. And social distancing is helpful if you're in an enclosed environment and somebody is symptomatic and there's droplet spread. The second mode of transmission is airborne. Now, airborne, we're just beginning to find out about airborne transmission for coronavirus. We know that's a common spread from other types of viruses. So airborne transmission would not be stopped within a 1 meter or 2 meter social distancing radius, and it's likely to linger in the air for far longer because the airborne transmission is smaller than the droplets. And the third mode is, so that's where social distancing comes in for the droplets. Airborne, it wouldn't be as useful. Then the third mode of transmission is what we call fomites, which is where you may touch a contaminated surface. And that's where wearing of gloves come in. The problem I have with gloves is that one, we don't know if they work, and two, we know that the virus will live for longer on the gloves than they would on your hands if you are washing your hands. And the only strong evidence we have so far for all of these prevention measures are actually for washing your hands properly with soap and water, and also sanitizing your hands. And I would strongly recommend every 20 minutes either washing or sanitizing your hands. The masks, actually, it's a very divisive issue, and there's probably too much to go into too much detail here, but I probably will write a post about that later on in the week because I'm getting a lot of questions. So the masks, as you can imagine, are not going to stop the particles of that size. The evidence so far that we have is from other viruses of similar size, and there are 3 meta-analyses, which is a pooling together of all of the available studies. So it's a very powerful level of evidence. And they show that masks are effective in very specific circumstances. So if it's an N95 mask, which has a filter that it's small enough to block off that level of particle. Most masks that you would be able to buy have a particulate matter of 2.5, which would not block the virus.
I mean, I've been sent a really lovely mask, and I've forgotten to bring it up now, but it's a Breathe Easy mask, and it does have a filter which you can then change. So it's a permanent, and it has a really nice seal, just like in hospital when you go and you have it fitted on your face. So I've yet to use it, but tomorrow on the tube I'm going to try and use it, and I'll take a picture and post it. And I'll see how well it goes. But I mean, I think
so. The other
false security, I think, you know, of false sense of security, wearing masks or gloves, that people may not wash their hands frequently enough, or they may be touching, you know, or fiddling with it. Yeah.
So I just want to touch on the other cases where it works. So the mask's only been shown to work indoors, and if the person wearing the mask has symptoms. So we don't know if they work at all if you don't have symptoms, and we don't know if they work outside. And then there are, as you say, false sense of security. The WHO recommend wearing masks if you can't put any of the other social distancing or measures into place, for example, on public transport. So that's when I would recommend them. So if you are high risk, I would recommend you wear one. If you are visiting somebody who is at high risk, then put all the measures into place, including a mask, is my recommendation. Obviously, some places like public transport, they're mandatory.
And what about
if they're not mandatory?
Travel? What about planes? Because you know you can't take distance. You're literally, you know, sort of touching people on each side, and then you know wearing a mask. I mean, and some of those surgical masks, like you said, are I don't know how much actual protection they're giving you.
Yeah, so any indoor environment really, would be a pub, a restaurant, airplane. I think you have the same issues. It's difficult to distance for the 1 meter or 2 meter, and you are in an enclosed environment for quite a while. But the estimates for international travel bringing cases over here are quite low. If you're traveling to another country, there are a few things to consider. In addition to the flight, you want to make sure, well, we'll look at the quarantine on the other side. Most travel insurance does not cover coronavirus medical or care for coronavirus, so you need to bear that in mind. So Europe is a safe bet in that case, because most people have cover. And also you want to look at the quality of the healthcare system where you're traveling to as well, in case you do need it.
And that's really, I think that's really important what you've said there about not having insurance. Your insurance won't cover coronavirus outside of Europe. And within Europe at the moment, I suppose, because we're still a part of Europe, Brexit hasn't happened, you know, I suppose we're still, we've got an element of cover there. Let me ask you, you know, something that you particularly, I think, enjoy and you know, close to your heart is gyms. You know, you mentioned gyms. You know, what about that?
Yes.
I mean, I don't know what to say about that, because I'm thinking all of that sweat, you know, even when it's not coronavirus times, you go onto a machine after somebody and there's sometimes a pool of sweat, or hot yoga and there's a pool of sweat. So, so what do you think about gyms opening?
Yeah, so I think there's a common perception and I think misconception that gyms are more unhygienic. And I think it doesn't necessarily have to be that way. And when gyms open, hopefully on the 25th, they have been asked to put in special measures to ensure that some of the precautions are taken. And again, all we can do is look at places where they've already opened up. And again, there was a very nice study, I think it's from Iceland, where they looked at over 3,000 people. Half of them had been going to the gym, the other half had been doing other activities outside, but not using the gym. And there was no difference in cases between in people going to the gym and people not going to the gym. And so these people were going 3 times a week for several weeks. I think there was one out of 1,800 people visiting the gym, there was 1 case of coronavirus. So the risks again are low. I guess you have to be sensible. If you have any symptoms at all, please do not go to the gym, and you wouldn't want to put yourself or other people at risk. So you'd hope that the only people visiting the gym are actually healthy, at low risk of having COVID themselves and transmitting it to others. But so far, from what we know, we think it's safe.
Because, I mean, it's really important, I think, to think about sort of mental well-being, physical well-being in the longer run as well. You know, people, you know, exercise is really good to sort of boost your mood, general health. And I think, you know, one of the things that we're worried about at this moment in time is that we, you know, later on down the line, are we going to have to deal with more cancers? Are we missing heart attacks, cardiovascular disease because, you know, of late presentations, or people not going to see their doctors because of, you know, sort of COVID? And the longer term, you know, mental well-being risks, suicide, domestic violence, you know, there's a huge you know, sort of element of general well-being that we also need to sort of balance, as well as, I suppose, the economy.
Absolutely. So I can see some of the comments that our listeners are putting in. It's a very emotive topic.
Yeah.
A lot of people rely on the gym and the gym community for their support, moral support, emotional support, in addition to obviously keeping fit and active. And I think these are all very important issues and factors we need to look at, in addition to obesity being one of the major risk factors for younger people for coronavirus.
Personally, one of the things was, for me, going to the gym, you know, anxiety. It was a really, you know, I'm not somebody who does yoga, mindfulness, you know, to go and do some exercise, you know, I think, you know, from an anxiety and calming perspective, you know, I found that really useful. And you know, there is that sort of sense of, I suppose, you know, just seeing everybody around you, not feeling alone. And considering, you know, there are lots of sort of single people out there, I think it's quite a nice environment to be around and also be healthy. So, you know, I think we do have to balance everything. Let me just see what's it. Gyms need to make it to ensure maximal safety for a return. I think gyms have been given lots of sort of guidelines, and they've had to put lots of systems in place. So I think, you know, they're not going to open up like they were before. I think there's a lot of them, a lot of guidelines that have been given to them, and, you know, sort of measuring out the space between workout machines and things like that. And classes, I suppose, you know, numbers will be restricted.
Yeah. So I just want to answer this one point. I think I've got most of it. So it says exercise is only positive. Why opening a gym is more important than continuing cancer treatment. So I didn't get to answer the full question. A lot of people, hospitals quite rightly had to limit non-emergency care. Now, cancer treatment can be seen as emergency care, and not all cancer treatment was cancelled. So cancer treatments, where feasible, were ongoing, and where feasible, they were being continued in separate institutions. Now, what we do know is that if we compare this year to last year, there were 40% less people going in with heart attacks over the 3-month period, and 60% less people going in for new cancer diagnoses and investigations. Now, obviously, we will now have to play catch up. Some of these people there'll be some overlap between these people and the people who were being seen for coronavirus, but there will be some catch up. So absolutely, we're not choosing gym over people being seen in the hospital. We want both, but it's very important to point out that not everybody can exercise outside, and exercising and building muscle is very different to exercising and building cardiovascular capacity outside, and we need both, particularly for weight loss. Both are needed. And there are many psychological and social aspects of the support given from the fitness sector and fitness industry, which cannot be provided. For example, we know that a large proportion of the population now are suffering loneliness, isolation, which has got worse over the last few months. And so these are factors, these are things we need to factor in. You mentioned the economy, and clearly, we're seeing a lot of anxiety, stress, people with difficulties with sleep, mental calls to helplines increasing, calls to suicide helplines have gone up, domestic abuse, calls to child lines have gone up. So there are many factors. Now, it does need the right team of decision makers to put all of this together and put the data from all of these together to decide what to open and when. But what I can say is that from the data we've seen so far, gyms are not going to pose additional risk from what we've seen compared to, say, pubs being open and people being in enclosed environments in other settings.
Yeah, no, absolutely. I know that, and I think that's really well said. So moving on from that a little bit, when's the vaccine likely, or when do you think a vaccine may be on the horizon? And what about testing? We hear a lot about testing. How useful is it? There's the antibody test. We don't even know how long somebody retains their antibodies following on from following on from coronavirus. So how useful are all of these tests that are out there?
So the two types of testing. One is the antigen testing when you think you have symptoms, and that will tell you if you have coronavirus there and then. The sensitivity is around 70%, which means in 30% it may not show up, and you may need more than one test if it's negative. And then the second type is the antibody test, which it would be positive a couple of weeks after you've had coronavirus. Now that's important, particularly for, say, healthcare workers to know who can go back to work. Now, the antibody tests are where many of the questions arise, because a lot of people seem to develop antibodies, but then they die down pretty quickly. So if we test people, say, 5 or 6 weeks after they've had coronavirus, 1 in 3 people wouldn't have high levels of antibodies. Doesn't mean that they're not immune. So there are 2 types of immune cells. There's the B cells that produce the antibodies, and then there are the T cells, which are activated from previous exposure to different types of coronavirus, for example, the common cold. And so most of the people, even if they don't have antibodies, their T cells are activated. So just because they don't have the antibodies doesn't mean they're not immune. Now, I've seen very mixed stories about how long, usually in the media, I think it was the Daily Mail, how long people remain immune. Now, we can't just use the antibody test for that, because we need to look at the whole of the immune system and not just the antibody test. Now, for most viral infections, the first infection is by far the most severe, and the second time you either are immune to it or it's a much milder form. And there are a couple of exceptions to that, but the vast majority of viral infections behave like that. So we have no reason to believe this will be any different. So we think subsequent infections you'd either be immune or you'd have a much milder infection.
And what about vitamin D? I mean, I talk a lot about vitamin D, saying how good it is for you from sort of a general health perspective, but we've heard a lot about immunity, it boosting your immunity, it helps with coronavirus. It might be one of the reasons why, the Black and ethnic minority population are at higher risk, because they have lower vitamin D levels. I mean, it seems to be flavor of the week one week, and another week, there's another study that then says no. But I mean, overall vitamin D is good for you, but what what are the sort of the information when it comes to coronavirus and vitamin D?
So have you been prescribing vitamin D in the last
No.
few
I
months?
mean, I do that for general health, you know, from the point of view.
Yeah.
I don't do it from a point of view of coronavirus. It's not one of the things I say. I say it for generally, you know, from you know, sort of aches and pains, you know, bones and everything like that, and from a mood point of view, but not specifically for this. But I think
Yeah.
the papers were saying, you know, having this level of vitamin D could help more so with coronavirus, and then the following week there would be something contradictory, and you're thinking, well,
Yeah.
where do you stand on this?
Yeah, so I've only seen one reliable study on this, and it showed no benefit from having vitamin D to prevent you from coronavirus. But we know, as you quite rightly say, there are benefits for bone health, and particularly for menopausal women. I think it's very important to look at. And particularly as we've all been inside, not exercising as much and not getting as much sunlight, I think we definitely need to look at vitamin D for other health factors, but it's not going to prevent you from coronavirus as far as we know. I didn't answer the vaccine question, but are there any other questions from people listening in?
I haven't seen any more, but I mean, it is a really emotive subject. I think, you know, people, I mean, from, you know, mental health point of view, sort of work, you know, financial, social isolation. I mean, there's a lot of things going on. And, you know, I've seen it with my own patients that, you know, at the beginning there was a sort of surge in anxiety, not being able to sleep.
Yeah.
Things sort of plateaued for a bit. And then it, you know, then another sort of, I was going to say another wave, another surge of it, sort of when we're sort of restarting, and you know, lockdown is when lockdown has been lifted. There's another kind of surge of anxiety, uncertainty, sleeplessness, and homeschooling's been, I think, really hard for a lot of families, particularly women who tend to shoulder most of this. So, you know, obviously, as I see a lot of women, you know, that there has been that element as well of additional stress on them as well.
Yeah, it's interesting because speaking to male colleagues who are making decisions at company level for future ways of working, they're putting this forward as a huge boost for flexible working, particularly for parents, and that seems to make sense and be common sense, but counterintuitively, I've seen quite a lot of written on women really bearing the brunt of the homeschooling and finding it difficult to work at home. And just I'm a data person. I like data. If you just look at the number of publications that have come out, a lot of publications on coronavirus. If you look in general, publications by women have gone down by quite a lot, and publications by men have gone up. And I hear anecdotally a lot of stories that women are really taking the brunt of having to care for kids at home as in addition to their work. And I've see stories about women actually being fired because their children are disruptive on Zoom calls, etc. So I think we need to find a new balance and a new way of working, not just assume that this is going to make everybody's life easier and make the work-life balance.
One of the things is for me, for my patients that are perimenopause and menopause, and when I go sometimes into companies, I do talk about flexible working. And I think one of the positives that may come out of this is at least employers can see that, you know, women are able to work, you know, flexible working should be something that could be offered more so than before. But you know, like you said, I think one of the other things that has come out of the data is that women's careers have been interrupted much more so than men's, because, you know, they're bearing the brunt of it, you know, sort of homeschooling, cooking 3 meals a day almost. So there's a huge element of you know, that the impacts on them. And that's really interesting, you know, just taking the data from publications, you know, just something like that, and for you to come out and say, you know, women's publications by women have gone down, but whereas by men it's gone up. And I think that is something that we do need to think moving forward, that flexible working doesn't mean that you have to stay at home. I think there may be a little bit of sort of redressing the balance. But I don't think all women want to stay at home. I offered one of my patients today, I'm offering Zoom calls as well as face-to-face. So I said to her, happy to do a Zoom call. And she was like, no, I've got 2 teenage children at home. I'd love to come out and come to clinic. And I was like, okay.
I can relate to that.
And I was just like, okay, I was trying to be accommodating, and I thought I didn't want to, I do prefer to see people in clinic. I think it's really nice, nothing beats face to face. I think, Zoom doesn't do that, and you get Zoom fatigue. But when she wrote that, I thought, in a nutshell, I think that's what a lot of women are feeling. They just quite like the idea of getting out, having a bit of me time, and just having a bit of a break from the humdrum of home. So I think it is something to sort of put into context. I think we're learning a lot from this. The world's gone a bit more digital, a bit more accepting of sort of using technologies. But I think the pendulum shouldn't swing one way. We need to get a bit of a balance in the middle. So
yeah. So some of the work I do is on setting up healthcare systems and healthcare infrastructure, and I do quite a lot of work on digital health as well. And the conversations for making healthcare more digital have been going on maybe for a decade. And I think it's fair to say doctors have generally been quite resistant to that
not me, but
until. No, not you at all. But until now, when suddenly it was forced upon most doctors. So how do you think the future will look for healthcare interactions? Because obviously there are pros and cons in terms of accessibility, but as doctors, there's so much that you glean from that face-to-face, and a lot of the social issues, I think, and the verbal clues, non-verbal clues, you wouldn't get online.
I mean, I think some people are sort of heralding it as, oh, it's amazing, we're never going to do face-to-face or anything like that. But I think they forget how much, like you said, that those clues. I also, when I was in Oxford, worked in a practice where there was a lot of Southeast Asian families, and often the daughter-in-laws, it was a reason for them to come get out of the house. And I almost set up a coffee, a lunchtime drop-in, so that they could come out. They come out with coughs and colds. And if we've made it all digital, I think it would be, for me, I don't think it's the right thing. I think you have to have a bit of a mix. I think it's great to be able to have that accessibility. I've managed to see patients in or consulted with patients in Saudi Arabia, Spain, France, during this time. And it's been really good to be able to do that aspect of digitalizing electronic prescriptions, even blood test kits that you can send out. But I think, there's a lot to be said from that interaction, that face-to-face interaction. So for me, that's always going to be number one. But I think it's great to be able to use technology advantageously and, cover a huge area, and also, cover the numbers of patients sometimes. Sometimes that's all it's needed, and it saves the patient a lot of time as well. Not having, I think people should be able to choose. I think it's choice rather than, sort of being made to do one way or the other.
Yes, but logistically, how would that work for you if you need to offer both?
I've been doing it now. I have been doing it. So, I've been doing Zoom calls, and I've been sending out, I've worked with an NHS lab now to do blood testing kits. So I can send them out kits for me, I suppose it's a bit easier because it's more of a niche. I'm perimenopause and menopausal women. It's not the whole spectrum of general practice. So then I can send them a blood test, and particularly, and then I can get their prescription delivered to them. But, particularly it would be nice to at least have the first interaction face-to-face, and then the reviews can be done digitally if a person so wished. So it works well and okay for me. I'm doing a bit of both, actually. So, but I think from a general practice point of view, it'll help to maybe cover a lot of the numbers of consultations as well. So I think digital health, it is a way forward in so many ways. But I think, not to forget that actually coming to see your doctor is a lot more than, science. There's a huge sort of holistic element to it as well.
Yeah, absolutely. And I wonder how much of that, if any, is gained over a Zoom call.
Yeah.
Quite a few comments here. I was just reading the comments. Women saying they prefer to go into work, and I think that there are many kind of unmeasurable, intangible benefits of that face-to-face, and maybe women benefit more from that face-to-face as well, because we tend to be more social creatures.
I have to be honest, I used to also say that going into work was a bit of a break for me. You know, I found it easier to go into work than being a mum at home, because I used to work part-time, so I actually found those days harder than the days going into work, because you had more of a structure, you were able to get dressed up a little bit, you know, whereas I think, you know, the day-to-day at home is much harder. So yeah. I think we're working our way forward. I think just to sort of bring it back to COVID and post-lockdown, I think the thing that really struck out to me was that you were saying hand washing every 20 minutes is your top tip. And yeah. And what else would you say? Anything else from a headliner point of view?
Yeah, I think try to be selective where you get the information from as well. You know, there are a few people who I would recommend to follow in terms of real, more realistic advice on risk and what's safe to do, what isn't safe to do. And also, I think, for example, masks. I will do an article on this, but
that'd be really good.
There seems to be a lot of kind of naming and shaming of people either who are wearing masks or aren't wearing masks, and I just want to drive home that we really don't know whether these masks are helping, and there are some cases for them to be counterproductive as well. So really try to follow. I think there's a cancer doctor, Carol Sikora, don't know if you know him, he's on Twitter. He always gives good information. David Spiegelhalter.
Well, I think that would be a really good post if you could do that one as well, Kosa, talking about death and not talking about death. When I'm saying the death rates, and you're saying about you know, making those comparisons, you know, those were very interesting statistics. So, you know, I'd really like to see that in a little bit of a nutshell and a post, and I think I would welcome that as well, and I think that's a really useful one. So yeah, so we've been talking for ages, actually longer than I had anticipated, but it's been really good, and I feel like we could just carry on talking more and more on this subject.
We should let people go.
Yeah, I mean, it's really good, and thank you for coming on and sharing all of that data, all of that information. It's like you're a walking encyclopedia.
Well, unfortunately, I've got coronavirus coming out of my ears for the last few months, so I should know enough about it. But maybe we could do a follow-up session after a few weeks, because things are changing quite rapidly as well. Right, it would be nice to do a follow-up where we say that the risks are much lower and the precautions are different, and the gyms are open, and patients are getting back to hospital, etc. So maybe we do a follow-up one.
I'm sure you'll be at the gym when we do the follow-up one. We could just do it live or something. But thank you very much.
That's not a bad idea. Lovely to speak to you, Shahzadi.
Really lovely. All right. Bye-bye. Okay. Thank you, everybody. Thank
Bye.
you for tuning in. Bye.